Now, I will switch gears now to a very exciting new therapy for small cell lung cancer. And actually, this is the first bispecific T-cell engager that has been approved in solid tumors. And it was approved in small cell, which is a very small group of lung cancer. And this drug works differently. It's not chemotherapy that is killing every cell of the body. And it's not a checkpoint inhibitor that is kind of waking up the immune response by blocking PD-1 inhibitors. This is a bispecific T-cell engager that binds DLL3, which is a marker on the small cell, and it also binds T cells, and it brings them rapidly into direct contact so that the T cells, the immune attack cells, start recognizing small cell. And this forced movement of T cells around small cell has shown really impressive results for patients that had been progressing after chemoimmunotherapy and other second-line therapies that don't work very well. So the data that we first heard about was the phase 2 data from the Delphi 301 trial, where patients were randomized to two different cohort doses based on different doses of the medication. But the overall response rate was very good just for the lower dose at 10 milligrams, which is the approved dose, at 40% overall response rate. And these are patients who are treatment refractory in the second-line setting, small cell lung cancer. There is, however, an FDA box warning for this drug that because it quickly kind of engages the immune system, you can get a more dramatic immune response that is very important to understand. So one of the things that they saw in this trial was something called cytokine release syndrome, where all of the immune cells get activated and patients can develop hypertension, shortness of breath. And because this can happen within 6 hours or a day of treatment, these patients have to be admitted in the first 2 infusions to monitor in the hospital setting for that. There was some neurotoxicity described called ICANS, which is an immune-mediated kind of response on the brain that can also cause inflammation and lead to confusion in some patients. So for this reason, especially the cytokine release syndrome, patients have to be admitted twice to the hospital for a 22 to 24-hour observation. After that, they can be managed as outpatients, but they have to be monitored at least for 8 hours for the first few cycles so that we understand that they're not going to have hypotension, low blood pressure at home. Well, regardless of this box warning, this drug showed a response on patients that were now not responsive and had no option. So the 10 milligram dose showed that the majority of patients showed a response. And most of these responses lasted over 6 months. So this is definitely moving the needle in the second-line setting for small cell lung cancer in a very meaningful way. Now, this summer at ASCO 25, we heard about the Delphi 304 data, which actually was the confirmation second-line study comparing Tarlatamab to standard of care. And standard of care is usually topotecan chemotherapy, irinotecan, and even lurbinectin. I don't think there were many lurbinectin patients, but in our practice, there were 47 here that were lurbinectin. And so chemotherapy versus this new immune bispecific T-cell engager response. So these were patients who had progressed on small cell lung cancer, have received first-line chemotherapy, immunotherapy, and had a chemotherapy disease-free interval of at least 90 days. Or there were some patients have progressed sooner and some patients have progressed later. And there was no crossover allowed. And everybody was very excited to look at this data of survivals that were reaching over a year mark on patients that in the past had a lot of toxicity and not a meaningful response in the second-line setting. So when you look at these patients that already had been treated with chemoimmunotherapy, some of them that were really treatment refractory, progressing within 6 months, we were able to see that at 6 months, more patients, 76% of them were alive when they received this treatment versus 62%. And at 1 year, again, 53%. So the median overall survival was 13.6 months for patients who received this therapy versus 8.3 months for patients that were fit enough to get chemotherapy. And there was also some crossover allowed, which is good because then you can see that it's more real-world data that some of the patients did receive Tarlatamab on the control arm, but not a high amount of them. Now, the survival benefit was consistent across pre-specified patient subgroups, and very important for us to see that there was efficacy on older patients, because a lot of patients with small cell lung cancer have many comorbidities and are older patients, so we want to make sure that this treatment was tolerated in them. Patients who received immunotherapy and did not receive immunotherapy responded. Patients that progressed really quickly after chemotherapy within 90 days also responded. Even more so than patients that progress after 180 days. So this is really an area of need and a needed treatment for patients that were platinum refractory. Patients that have brain mets also responses, and we have seen reports that this treatment, it can cause some neurotoxicity, but it can also cause efficacy in the brain, and patients have had responses, and progression in the brain is a significant area of morbidity for patients with small cell lung cancer. Patients with high burden of disease with liver metastasis also responded, and there was improvement in patients regardless of the treatment that they had received previously. So again, I will highlight that the age didn't matter, and that the presence of brain metastasis and liver metastasis, also those patients responded. So even the sickest patients did well. Now, the toxicity from tarlatamab is real, and the cytokine release syndrome is something that our partners who have been doing treatments in the hematology space that cause some of these side effects, they understand this well, and some of this can be managed as an outpatient, but it's important to recognize, and for the FDA still requires that patients be admitted for those first 2 infusions. Now, the good news is most of these side effects were grade 1 and grade 2, meaning that it was basically a low-grade fever, but not a serious hypotension event where patients require ICU admissions. So most of them were grade 1 and grade 2. And also what was important is the timing of this. So the tarlatamab CRS with the first 2 infusions was seen in about 6 to 8 hours in about a third of patients, and it was grade 1, and 48 hours was definitely much less that you will have any significant toxicity. The neurotoxicity is more rare, it's in the range of 6% of patients, but important to recognize those changes. But the CRS, I have here an image, it can really present in many ways because it can lead to severe hypotension and organ dysfunction, so that's why patients have to be admitted to the hospital those first 2 times. Now, even with that being said, the efficacy is there. And what is really critical is that this is creating an immune response that we never had against small cell lung cancer, which is such an aggressive cancer. And some of these responses were durable. So the median duration of response on the tarlatamab arm was 6.9 months compared to 5.5 months from patients on chemo. And truthfully, after patients make it to the initial kind of immune responses, they're tolerating the treatment much better because it's not chemotherapy that is cytotoxic. So I think that also contributes to how these responses are durable. The objective responses was 35% on the tarlatamab arm versus 20%. So you have a more significant shrinkage of the tumor. And there were even some complete responses, which we never really see, at least we didn't see in this chemotherapy subgroup. But there were definitely a lot of them were stable disease and partial responses that were durable for patients. Also, the important thing to note is that the median time to objective response was around 1.5 months.